We will conclude with Dr. Auerbach, who's clinical professor of medicine, this time it's right, at Georgetown University, and who is one of the experts in the use of intravenous iron, has published a lot on the issue, and maybe he can convince us that intravenous iron can help conserve blood transfusions. Dr. Auerbach.
I touched the screen to move the slides, is that right? Okay. Well, good afternoon. It's thrilling to be here. I've been working with intravenous iron for 30 years. It's only in the last few that anybody cared. And I would like to take you through some of what I think are the myths surrounding the use of this product and where I think it needs to go. I am constantly being criticized for doing things that are relevant to the United States. The problem is it's where I live, and the Lone Ranger was one of the heroes of the Western television shows when I was a little boy. And the William Tell Overture used to introduce him, and I really believe that intravenous iron is going to be the Lone Ranger for both ESAs and the Western blood supply. And I hope that the data presented here today should certainly make you ask why this nearly always successful and now virtually completely safe, relatively inexpensive and easy to administer therapy is not used more. And the answer really lies around the fact that there is a huge inappropriate folklore surrounding the use of intravenous iron, and that it is dangerous. You were certainly taught that in medical school. I was taught that it should be reserved for only life-threatening situations. Intramuscular iron used to be used around the world, which is painful and disfiguring often to the area that it's injected. And this folklore is perpetuated by the misinformation and misinterpretation of the true clinical nature and incidence of side effects. It is never, the use of intravenous iron, as of 2008, has never been the subject of an educational session at the American Society of Hematology, the European Society of Hematology, the American Society of Clinical Oncology, the European Society for Medical Oncology, or any of the internal medicine organizations. Not once has there ever been a non-pharmaceutical sponsored educational session on the use of this product that seems like it can do so much. So can we reduce, take the pressure off the Western blood supply? And it is my opinion that the answer is easy. We need to use much more intravenous iron in surgery, obstetrics, and inflammatory bowel disease, and we need to give it in a convenient and safe and less expensive and more effective, well, equally effective way of infusing it over a short period of time. And I will show you the data from my practice that a 90-minute infusion of this material is safe and effective. Further, the 4 to 6 hour infusion really came from my published data in 1988, where I was ignorant of the safety of this product, and I actually randomized patients to get their intravenous iron over 4 hours or 12 hours. I just didn't know back then. This is a slide that Dr. Maniatis showed you today, and with the huge cost of transfusion, by the way, you're getting a bargain in Europe. It is $3,012 for 2 units of blood in the United States. And if we now have to worry about getting blood out of storage quickly, can you imagine what that will do to cost? You saw the individual today who has done the most work in the world on the use of intravenous iron in decreasing transfusions in surgery. I quoted him extensively in my reviews of this topic, and I want to add some unpublished data to the already excellent data that he showed you. You saw Dr. Munoz and Garcia Ursh's data in hip fracture patients where 3 doses of iron sucrose were given on different days, with 1 dose of erythropoietin weekly, with a significant reduction in transfusions in that patient population from 73 to 46%. I'm sorry, in here from 53 to 19%, and in this study from 73 to 46%. With 80 in this study here, which is unpublished but reviewed in a recent review that we published in Transfusion just a couple of weeks ago, Dr. Picard, at the behest of the Jehovah's Witnesses in Baltimore, Maryland, started a blood-free surgical or bloodless surgical program by offering surgeons 2 doses of recombinant erythropoietin and 1,000 milligrams of intravenous iron infused over 4 hours. My fault. In that group, there were 35 patients treated by 1 physician in an orthopedic practice, compared to another member of his practice not using the blood conservation program. And at the end of the perioperative period, 80% fewer patients who received the bloodless medicine program were transfused. Now these are observational studies, but coupled with the ubiquitous results with no contradictory evidence published anywhere, it must make us take cause. Dr. Braga looked at 151 anemic patients who received iron sucrose for 12 days, 12 different days, and 4 patients in the IV iron alone group received transfusions versus none in the iron plus EPO group, suggesting the synergy between the two. And Cosmodakis looked at 75 patients with non-metastatic GI malignancies who received iron sucrose alone or with ESA, and patients receiving IV iron plus EPO had fewer plus ESA had fewer transfusions compared to IV iron alone. The converse has been done by me and several others in oncology, showing that intravenous iron reduces EPO requirements and vice versa. The treatment, the decreased transfusion seen in obstetrics are all observational studies, but the observational results are really quite striking, from 20% to 0.5%, and from 50% of women being iron deficient at term, where a transfusion rate at 10% was seen, a marked reduction in intravenous iron was seen in this population. They're poorly powered observational studies, and will set the stage for the conclusion of what I hope is a brief talk. In inflammatory bowel disease, without wishing to be dogmatic, 100% of patients need intravenous iron. Approximately 2 to 4%, based on worldwide sales of products of these patients, get it. We are talking about a therapy that works 100% of the time in this population and is the only alternative to oral iron, which is directly toxic to the gastrointestinal endothelium in this patient population, worsening their disease, and it doesn't work, and it is the standard of care. Dr. Gaischi from Austria has done most of the work in this population using multiple doses of iron sucrose and showed a hemoglobin response in greater than 75% of patients and 95% of patients with iron plus EPO, and this makes sense because all of these patients have inflammatory bowel disease. For the first time, an appropriately powered study in oncology was done that was just published in the Journal of Clinical Oncology of April 1st in this year. Dr. Bastit showed that there was a marked reduction in transfusions of patients receiving intravenous iron compared to those receiving oral iron in cancer chemotherapy patients, and these data are probably independent of baseline iron stores, as the mean ferritin in both groups was greater than 200, and the mean TSAT in both groups was greater than 19. And although the data are not published in the paper, they're currently being analyzed, and it is my understanding that the iron stratification data hold for those transfused and not transfused. So in slide 2, why did I say we need to give this as a total dose infusion? Well, we need to sell the concept to the doctors who are going to do it. Surgeons are going to be reticent to say 2 to 4 weeks before an elective procedure for which they expect to be seamless is going to be a standard of care. But if we can sell it as an equally effective, less expensive, equally or less toxic form of therapy, given over 90 minutes once, ball game over, I think we have a real good chance of making this happen. It is much easier on the patient and doctor, and I have already said that it's less effective. The National Kidney Foundation in 2000 said it is unreasonable to expect home dialysis patients or patients with chronic kidney disease to endure multiple injections when a single injection in a single setting can be done, and it was part of the guidelines. I believe it is part of the 2008 guidelines that were just recently published. I'm going to make some recommendations that are based on my data. I want to say that these recommendations are not used in Europe. I disagree that they are not, but it is a minor point. One of the side effects of giving intravenous iron dextran is arthralgias and myalgias, and these side effects can be markedly reduced, especially when it is, when given as a total dose infusion, because I don't pre-medicate at all for smaller bolus injections from 400 milligrams and down. And I think this is a point to take home. If you give methylprednisolone prior to total dose infusion, you will markedly, and prior to and after total dose infusion, you will markedly reduce the numbers of arthralgias and myalgias that are seen. In 1988, when I published my first paper, it was we actually reported for the first time the arthralgia-myalgia syndrome associated with total dose infusion. There were 87 patients that were treated. 6 patients had concomitant anemia of chronic disease. There was no EPO given because there was no EPO invented yet. And all of the patients responded completely. There were no serious reactions. One patient had an acute reaction that resolved. This was with Imferon, a high molecular weight iron dextran, no longer available. This paper has never been quoted for any other reason than the arthralgias and myalgias that were described. The 100% efficacy in the iron deficiency and the 100% efficacy in chronic disease has never been quoted. In the early 1990s, we did a comparison of total dose infusion to bolus iron in dialysis patients. What you can see is there is no difference. And so if you're saying, why is it a big deal? And the big deal is that there is a $225 million savings in pharmacy costs alone as of 1994 in the United States. Just translate it to euros or kronas or pounds. $225 million of savings just in pharmacy costs alone for a more convenient form of therapy. These are the results of the last 100 patients that I have treated in my office. We are about to embark on a true kinetic study where patients will be randomized to different rates of infusion down to 90 minutes for doses of for down to 60 minutes, which I have not tested, for doses of 1,500 milligrams. The reason I use the 1,500 milligram dose is in the original oncology studies, 1,000 milligrams was given in several of the trials, and 1,500 milligrams seemed to give a better hemoglobin response. So we use 1,500 milligrams in 90 minutes, treated 32 patients with severe menorrhagia, 26 with angiodysplasia. I'm known for doing this in my community, and that's why I have so many patients who have angiodysplasia or Osler-Weber-Rendu or hereditary hemorrhagic telangiectasia. Diabetics get a lot of this. You see a fair amount of this in rheumatic patients taking NSAIDs. There were 17 pregnant patients, 9 patients with unexplained iron deficiency, and 12 patients with cancer not receiving chemotherapy, and 4 with chronic kidney disease. There was not a single adverse event in this population that required any intervention. 100% of the patients responded, and the pagophagia that was present, the ice craving that was present in the majority of these patients, disappeared the next day. Now, methylprednisolone is rarely used in Europe. Again, I disagree. I do not think that it is worth doing. Worth making a big deal over, but if you want to take a clinical vignette home, that's mine. I did give 2,250 milligrams to one patient who had stomach cramps the next day, and subsequent to that, we're not giving doses bigger than 1,500. Further, I don't think there's any data that it makes any difference. A test dose is required still. I don't think there's any data to support its use. In Europe, you have had the good sense to eliminate the remaining dangerous intravenous iron, which is high molecular weight iron dextran. You have no black box warning. We do. It continues to fuel the folklore, making this therapy perceived as dangerous. A recent paper in the Journal of the American Society of Nephrology, authored by George Rogers, myself, and others, recommends to the American FDA to remove this product from the pharmacopoeia. I think if you're going to give this, because of the potential vesicant nature of iron, 500 milliliters of solution will eliminate all of your clinical problems. 250 is probably okay, but I believe this is more comfortable. I routinely give the methylprednisolone. It's up to you. Give the remaining solution over 90 minutes. The disadvantages are you do get TDIs with this. You do get arthralgias and myalgias. They're very rare if methylprednisolone is used, and if they occur, nonsteroidals for half a day to a day eliminates it 100% of the time. Now, I just want you to think for a moment, if you were given the choice and you were a patient with home chronic kidney disease or peritoneal dialysis, or before you were going on dialysis, if you were a cancer patient not on chemotherapy and you were iron deficient, if you were iron deficient for menorrhagia or chronic bleeding, or you were going to need iron before your surgery or before a gynecologic procedure, or with inflammatory bowel disease, and somebody said to you, you can come in every day 8 times for 5 minutes. With the new material, maybe even less than that, but you have to come in several days, or you can sit for 90 minutes once. What would you do? It is important to know that serious side effects of these compounds occur, but they are extremely rare. There is a not serious side effect that we published in Lancet last year in May, and that reaction was described by Steve Fishbane, who never published it, and that reaction says that you often, 1 out of 100 to 200 patients will get an acute arthralgia and myalgia, but there will be no tachypnea, tachycardia, wheezing, stridor, periorbital edema. And if 0 of those 6, I left out hypotension, the one that we really care about. If 0 of those 6 are present, that is not a serious reaction. Walk away, take your own pulse, come back, re-challenge the patient. It won't recur. Do not give diphenhydramine, Benadryl, which has a host of vasoactive reactions, making patients feel poor, often the cause of a misinterpretation of an SAE. Do not give Benadryl or epinephrine for this reaction. Give nothing. It won't occur. With the exception of total dose infusion, you should not pre-medicate these patients with anything. There is a published paper in the American Journal of Medicine by Barton et al. From the University of Alabama that said in a consecutive series of patients receiving total dose infusion of iron dextran, the overwhelming majority of side effects were due to the pre-medication. There are now 2 studies in England and 1 analysis of all of the published data, one in renal failure and 2 in transfusion alternatives and transfusion medicine, saying that when compared head-to-head, these products are equal. There are significant cost savings and convenience with low molecular weight iron dextran and its total dose infusion. A practical approach, in my opinion, is choose your weapon. I am not going to say that low molecular weight iron dextran is a better drug than ferric gluconate or iron sucrose. You choose what you want. There's a significant cost savings in my country with low molecular weight iron dextran. If it's going to be a short bolus, pick your product. If it's going to be a TDI, you can only use iron dextran. The higher doses of the salts will make the patients quite ill. High molecular weight iron dextran should never be used. I think these are the dose parameters that will make it seamless and completely safe in your patient population. Do not pre-medicate these patients, please. My opinion, use methylprednisolone before and after a TDI. Not a serious issue. To summarize, these rules, I believe, will make iron completely safe for you. Avoid the high molecular weight product. Beware. Well, you don't have to beware. It's Europe, so skip the next part. You all have had the sense to make this product go away. In the U.S., the majority of our hospitals still buy it. It's scary. I think you have to use a test dose if it says to use a test dose. When it stops saying to use a test dose, I think it'll be completely reasonable to stop doing a test dose. Do not pre-medicate except for TDI. Patients intolerant to low molecular weight iron dextran will usually, and which I think is extremely rare, will almost always do well with ferric gluconate or iron sucrose, and do not recommend the maximum single doses of the salts because your patients will get stomach cramps. This is where I want to go. Dr. Munoz disagrees with some of these points, and I'll explain why a little bit, but I want to take 1 minute. I want to take elective surgical patients and with these hemoglobin numbers and randomize them to oral iron, intravenous iron, or intravenous iron plus ESA. The number 12 is the number that we can't treat with anymore. Serum ferritins will not decide who gets treated because across the board, iron has worked in iron replete and iron deficient patients. And my conclusion slide is not printed because I don't like to say things, I don't like to put in writing my most dogmatic statement, which is intravenous iron is seriously, inappropriately underutilized. I believe we're going to have data soon that will change that. Thanks.